But the way a biomarker has to be developed is very analogous to the development of a drug. Drugs are approved for a specific indication. Where in the illness, in a patient's illness, regardless of cancer type, do you need additional therapies? In most cases, this is many situations, unfortunately, but now there are very specific points in an illness where a drug will get an approval. So for biomarkers, instead of the quote indication, what you're trying to inform is a decision. So for example, if I'm looking at a cohort of patients and I want to group patients into those with a favorable or unfavorable prognosis, I can measure PSA, high versus low, different outcomes. I can measure the presence of disease in the liver versus not. Similarly with CTCs, high number present versus few or none, another prognostic factor. But the first step, and if you think of a drug, it has to have a very strict formulation. This is how it is every day. For a biomarker, you have to show that the measurement is reproducible and it's, quote, fit for purpose or analytically valid. And that is the first step to start doing the clinical development, which is very similar to the phase 1, phase 2, phase 3 that we apply in drugs. But it really boils down to the decision. So, for example, what's being done more frequently now, and what happens in diseases with mutations, we know, for example, in lung cancer, if a specific mutation is identified, there is a drug specifically targeting that mutation and showing the presence of that mutation says, this is a drug that will help this patient and should be used. So there is the example where the biomarker is informing the decision to predict or not whether a drug will work for a patient. The same is happening to a degree with prostate cancer with the what's called the ARV7 protein or message, which can be detected either by RNA methods or it can be detected by protein staining. Working with EPIC, we know that if the AR is signaling, it's in the nucleus. So a assay was developed to look for the protein biomarker in the nucleus of cells. We then looked at cohorts of patients who were treated with the hormonal agents versus chemotherapy. We predicted that a drug that binds to the receptor, which is missing its binding center, which is the splice variant, would not be sensitive. That is the finding. And similarly, if you were using a taxane, which doesn't really care about it, we did see that patients responded. This was first shown by the group at Johns Hopkins. There are a number of different assays that are available, but the test work we did with Epic Sciences, looking at cohorts of patients from Memorial, first cohort, discovery, second, validation, where we obtained some specimens not only from New York, but Canada and the UK, similar. And then Andrew Armstrong working on a prospective trial called Prophecy, consistent results. That enabled a showing that you had clinical benefit, which is essentially the approval, if you will, of a biomarker, which means that if you use the biomarker test to make your decision, in this case, the choice of a drug or not, use of a hormonal agent versus a taxane, is the patient's outcome better? And if you can show that clinical utility, that's the key to third-party coverage and ultimate approval. The real important thing with biomarker is what is the decision you're trying to inform? So what we will often do, if let's say, working closely with our basic science collaboration, and they identify a gene or some protein marker, and drugs are developed to target that marker. One of the things that we would like to know as a clinician is where in the course of the disease is that biomarker relevant? So for example, when we looked at the ARV7, We looked at patients who were treated with first-line hormonal therapy and then were progressing, the first castration-resistant clinical state, if you will. And the frequency of that alteration was less than 2%. So from a development standpoint, if this is not going to inform what to do with 98% of the population, that's not the place to do your program. As we went into second and third line, and the patients were exposed to the more intense hormonal agents, the frequency went up at each point. The same for diversity of the cells, of the different cells that you see, the heterogeneity, how diverse is it? First line, not so much, although there were some cases. More drugs, tumors more resistant. Resistance can happen by many mechanisms. You see the diversity increase even further. Going into the third and fourth line, you start to see more of the small cell neuroendocrine type differentiation, where the AR is missing. It's no longer driving the cells. PSA is no longer expressed. And you're really treating a different disease. And that is happening more and more as we're using more drugs effectively. And the type of resistance we see is becoming more what we say are stem-like, cells that can regenerate, but very difficult to treat. So one of the things we do is to study different points of the disease to say this is the point where there's a sufficient frequency and an unmet need. And this enables us to do these studies in a more informative manner, but also helping the most patients who actually need the better decision. What we're trying to do with EPIC is to do what a cytologist does. They will look at a cell and is it malignant or not? And we're trying to take that to a different level, is can we do ethnic profiling of the cell to understand their genomics? When we start looking at heterogeneity, we're just looking at the mixture of cells and how they appear under the microscope. But now it's reaching the point where not only can we do protein staining, but we can start doing molecular analyses. And if one understands what the phenotype is and how diverse it is, and you start to associate those molecular changes with response or not. The third marker we've looked at is genomic instability. This is 10 meg. What we measure is what are called large-scale transitions, loss of 10 megabytes of DNA across the genome. And one would start to see that cells that with high levels don't respond well to, are very resistant to a number of drugs, but may respond to PARP inhibitors, for example. So if we can do a phenotypic profile, we can essentially get an answer of how you treat a patient with the first scanning. So the turnaround becomes much more rapid. The cost goes down. You don't have to do individual cell characterizations genomically every time. So it helps you, one, develop the biomarker more quickly, but also to apply it and see where it fits. And that's where we are now with the phenotypic changes, the heterogeneity, the ARV7, and the chromosome instability. And we're trying to fit that into specific molecular profiles, which will help us guide treatment.